Again, we don't have so many positive cases today, but there are a few interesting ones. So this is a pleural effusion specimen. So when you check the requisition sheet, the clinician already wrote it that the patient had a history of pancreas cancer. So we know our enemy. And like yesterday when we talked about for the metastatic pancreatic cancer in the body cavity, such as ascites or pleural effusion, the tumor cell can be quite small and bland looking. So comparing to the adjacent histiocytosol cell, the nuclear is not particularly big. But the most important signs to tell that there are some mucin vacuole in the cytoplasm, and the arrangement is a tight, like a three-dimensional cluster. So this is metastatic pancreatic cancer, and it already like across the diaphragm into the pleural cavity. So again, here is a very tight cluster with three-dimensional like arrangement. You need to focus up and down to see through every cells. At the periphery, you can tell that in the cytoplasm, there are quite some orogenophilic mucin. So these cluster may be very like it may be very not obvious for you to identify under the low magnification, but on high power you can tell all these features. So it is very important that first that you know the history of the patient, what is the tumor or the cancer that he or she had. So this is the specimen from the same patient, the second specimen. Again, in this specimen, there are less like extracellular material, and you can see this is a bigger cluster with a tubular type of arrangement. And again, at the periphery, you can tell there are some vacuole in the cytoplasm. You see luminal border, and all these cells looks quite small, very small, comparing to the lung adenocarcinoma or the serous carcinoma of the ovary that we often see. So these can be really, really bland looking. This is positive for adenocarcinoma of the pancreas. So pancreatic cancer is getting more and more. The prevalence is increasing, and because our hospital is specialized for pancreatic cancer treatment, we are seeing more and more these type of specimen. So this specimen is from ascites, and the patient had a history of cholangiocarcinoma, which is less common than the pancreatic cancer, but they can have very similar morphologic pattern because they are like a similar organ with a similar epithelium. So again, you can see here's a very tight cluster, three-dimensional. The cell does not show striking nuclear atypia, but you can tell they are vacuole and some yellow material inside this vacuole. So it is most compatible with mucin. So to identify this very tight cluster is important. So again, this is a metastatic adenocarcinoma compatible with pancreatobiliary type. So we have a couple pap smear. The first one, the patient had a history of vagina melanoma, and we have seen her pap smear last year. And in the specimen last year, it shows like plenty of the tumor cell. In these specimen, a typical cell is very scattered, very few, and it's a little bit difficult to determine. So here is a cluster of high NC ratio cells. The nuclear chromatin pattern is not very clear. Here is a large cell with markedly degenerated chromatin pattern, but as well high NC ratio. So this cell is a little bit difficult to determine if it's malignant, or it could be like atrophy changes, but it definitely looks quite atypical. But if you want to be 100% sure it is a malignant cell, it would be very difficult. So we see a few cells like these because the chromatin pattern show markedly degeneration. It can be coming from the treatment effect. So here we see this is squamous cell, right? So this is squamous cell, intermediate cell with binucleation, but does not show more atypical change. So this is benign. So there are a few cells with really tight like arrangement and high NC ratio, but it's difficult to see through. So overall, I think the specimen is quite difficult for screening because the atypical cells are just very scattered. Here we see multinucleation in an intermediate cell, but we didn't see like hyperchromasia, coloricity change, etc. So scatter of these type of cell can be just reactive. Again, this is also an intermediate cell, and the nuclear chromatin pattern, I would say, is markedly degenerated. So if we only see 3 atypical squamous cells, it does not qualify to call it ascus. This is a more like definite malignant cell that I would call, because first thing that you can see, the chromatin pattern are preserved. The shape of the nucleus is very strange, and it is markedly enlarged with 3 distinct nucleoli. So this is definitely a malignant cell. So from these slides, I only see one cell that make me think it is definitely malignant. And in the other slide, I would say it's better than the previous one. Yeah, so these, you can tell, the chromatin pattern is vesicular, the nuclear membrane is irregular, there are a few nucleoli, so these are positive. And when we checked the biopsy specimen last year, it described that the tumor cell shows spindle cell feature. So the malignant melanoma have some spindle cell feature. So I think it is still a few melanoma cells in this specimen, and the patient is under immunotherapy. So comparing to the specimen last year, we have very scant tumor cell, but they are still there. The patient still have the disease. So we call this specimen positive and compatible with melanoma. The next specimen is a little bit tricky. The screener called these high seal. So let's take a look of the dot, the highlighted cluster. So overall, it is a age. It is a 61-year-old female. So you know, it's already she already has menopause, is in the menopause state, and the screener do highlight a few cells. In the low power, you can see there seems to be some hyperchromasia. But in the high power, you can tell that the chromatin pattern is very homogeneous. You didn't see any coarse chromatin. And if you take a look of the adjacent, like cells with naked nucleus, this is similar to the cells over here. So overall, these hyperchromatic crowded groups looks more like reservoir cell change or some changes due to atrophy. So here again, this is a cluster of squamous cells, and you definitely see some variation of the nucleus size, and it can appear to be a bit hyperchromasia. But when you see the chromatin pattern, it is very, very delicate. It is very, very homogeneous. So please do not overcode these as high CO. Okay, so again we see it does looks quite like a worrisome, but the cluster is very tight, and the chromatin pattern is very homogeneous, and the cell looks very similar to the adjacent cell with naked nucleus. So this pattern is throughout the entire specimen, and some of the area you see these very high NC ratio cells, but in the patient of atrophy, these could be just parabasal cell. And the one with more a little bit like glandular feature and somehow with some naked nucleus, it can be coming from the reservoir cells. So overall, I think the background, the overall presentation of the smear compatible with atrophy. The screener call it high CO. I think there are a few cluster that might seems to be a bit worrisome. I think under this situation, the best diagnosis would be atypical squamous cells cannot exclude high CO, ASCH. So the timing for using ASCH diagnosis, this is one of the timing to debate. There's a difficult to determine if it's an atrophic change or it is a high CO. I think for this patient it is atrophy, but I think this particular cluster is a little bit worrisome. It's okay to call it ASCH, and for the patient with ASCH, the clinician will manage it as high CO. They would go colposcopy to confirm if there is any lesion in the cervix. So I'm like debating if I should call it just atrophy or I should call it ASCH. It's very difficult. I want to call it atrophy actually, but because of these, I think this is within the spectrum of atrophy, but just the most like a typical one. I finally decided let's call it ASCH. But please do not call it high CO because it is most likely atrophy change, and if the clinician do a colposcopy and biopsy, it's most likely to be negative. So do not call this high CO. So the next pap smear is coming from a 40-year-old female. So as you can see, the specimen show quite similar amount of superficial cell and intermediate cell. So it's coming from a younger patient. The background is very clean. And through the direction of smear, you can see like these tiny cells with a little bit high NC ratio, and along with the smearing direction. So this is the typical presentation of shading of endometrium stromal cell. So these very, very tiny cells has morphology similar to the histiocyte that we will call these as histiocytoid cells. Some of the cell you can see there are some nuclear debris inside it because it's endometrium shedding, so the cell is under apoptosis. So when you see these relatively clean, like a shading of endometrium cells, we don't necessarily need to report it because it is most likely coming from the normal shedding cycle. So here you start to see a little bit of tight cluster. It's almost feel like an exodus over here. And we didn't see any glandular component. Okay, here are more. So these are all endometrium stromal cell. So we don't necessarily need to report it, especially if the patient is under age of 45-year-old. Here we see a cluster of exodus. So we can say that it's negative, and what is the last menstruation, like a date, the period, the clinician didn't mention that in the requisition sheet. So this is the typical presentation of the endometrium debris. And when you screen under the low power, you can feel like it's almost like I would say like a Milky Way along the smear direction. So the next pap smear is coming from a 53-year-old female. In this specimen, in contrast to the last specimen, we have more glandular component other than the stromal cell component. So here you can see this is granular debris. Some histiocytoid cells is compatible with the endometrium stroma. But here we do see larger fragment of glandular cells. And some of the glandular cells do show atypical changes. And there are some phagocytosis inside the glandular element. We can see the cell is bigger, the nucleus is bigger, some with nucleoli. So this is a typical glandular cell, and you can tell by the similar background that it is coming from the endometrium. So as well, it will the pattern is also along the smearing direction. Some of the cells, some of the glandular cells actually show more preserved nucleus, which suggests that this atypical glandular element is likely directly involved to the cervix. So the sampling can be direct sampling. So the patient already received DNC at the outside hospital, and it say that there is a high-grade adenocarcinoma in the DNC specimen. And she received MRI image study, and the study showed that there are endometrial lesion as well as cervical lesion. So the differential diagnosis for the image would be the endometrial cancer involving the cervix or cervical cancer. So in this pap smear, it looks more like a endometrial cancer. And because of these cells are much well preserved, it's likely we already involved the cervix, and the clinician has directly sampled the tumor cell, but there are still some shading, more degenerated one that present in these specimen. So we see two cases with endometrial component. One is benign, and these then I think we can directly call this adenocarcinoma, favor endometrial origin. So this is the case for today.